Bom dia a todos. Meu nome é Paulo Belmonte de Abreu, eu sou chefe do Serviço de Psiquiatria do Hospital Moinhos de Vento, e a mim coube, não muito planejadamente, mas um pouco inesperadamente, mas ter o papel de abertura e de auxiliar na condução desse Grand Round de hoje, que para nós é um motivo de satisfação e mais de ver de várias pessoas de todas as áreas da saúde, incluindo saúde mental, mas incluindo outras áreas da saúde, para falarmos de saúde global. Na verdade, esse é o grande termo para pensar assim, que saúde mental faz parte da saúde global, só que requer uma série de avanços e de novos conhecimentos, uma vez que as áreas de saúde mental sempre tiveram muito ligadas a um aspecto grande de subjetividade, que ainda marca elas, mas que gradualmente foram incorporando mais padrões de objetividade no sentido de se conseguir estudar de uma forma sistemática o sofrimento e a busca de uma saúde global das pessoas, que inclui saúde mental. Então, dentro desse projeto, o Hospital Moinhos de Vento incluiu uma parceria, quer dizer, de um membro já do serviço, que é o Dr. Christian Killing, que ele é um professor licenciado do Departamento de Psiquiatria da Universidade Federal do Rio Grande do Sul, da Faculdade de Medicina, onde eu sou chefe substituto também, então estivemos julgando e votamos por mantê-lo também licenciado por mais um período de 3 anos para poder tocar esse projeto que ele está desenvolvendo a nível global de saúde no mundo inteiro. Não só no mundo inteiro, mas saúde também para a pessoa em todos os aspectos físicos, psicológicos e sociais. E nesse período dele, ele se uniu a um grupo que tem uma ação global também de estudar tudo. E espero que vocês ouçam deles, porque quando eu fui buscar as publicações, eles realmente estudam tudo que a gente pode imaginar que precisaria ser estudado, eles estão estudando. Seja refugiados, seja pessoas atingidas por desastres ou áreas remotas, seja da África, sei lá, Venezuela, Etiópia, tudo onde tu imagina que possa ter, mas também em áreas urbanas, e de como trabalhar de forma sistemática e organizada também em grandes serviços em países tão desenvolvidos, e essa noção de que a saúde é global, não tem limite de país, não tem limite de renda, não tem limite de grau de desenvolvimento, e eles são um grupo que nos deixa impressionados, que parece tipo uma SWAT, assim, onde tem dificuldade, eles vão e estudam isso, né? E entendo que vai ser um grande acréscimo ao hospital entrar nesse esforço conjunto, e onde eles têm muita experiência e podem até não saber como tocar adiante essa questão, então, de saúde global dentro do hospital e juntando com todas as especialidades que trabalham aqui dentro. Então, eu vou passar para o Dr. Christian as apresentações iniciais do nosso convidado, que é o Brandon Court, que tem um belíssimo currículo assim, de publicações e fascinante pela originalidade, pela ideia de buscar estudar tudo que existe globalmente em termos de saúde. Eles vão nos contar um pouco depois, mas o Christian vai fazer a maior apresentação. Deixo com você, Dr. Christian Killing.
Obrigado, Paulo. É um prazer muito grande estar aqui hoje. É a primeira atividade mais formal que eu estou participando aqui no Hospital Moinhos de Vento, para além do nascimento das minhas filhas. Enfim, eu frequento o Hospital Moinhos de Vento como paciente até pouco tempo atrás, e agora essa nova oportunidade de poder estar aqui numa outra posição como médico, como psiquiatra, como pesquisador, está sendo uma alegria muito grande para mim, e ter essa oportunidade hoje de Grand Round, agradeço muito ao Dr. Nazi pela oportunidade da gente fazer esse evento aqui hoje, também é extremamente enriquecedor no momento que a gente teve a oportunidade de ter o Brandon aqui com a gente, né? O Brandon, ele é um psiquiatra e antropólogo, então ele tem essa formação dual que traz um olhar único, né, para o aspecto da questão da saúde mental. A gente tem a mania, né, tem um mantra que a gente usa na área da psiquiatria, da saúde mental, que é a ideia de que não há saúde sem saúde mental. No health without mental health. Tá? Isso é algo que a gente tem repetido sistematicamente nos últimos anos, porque, infelizmente, apesar de a gente ter uma redução de estigma relacionado à saúde mental, ainda em 2025 falar de saúde mental é um tabu em várias situações. Né? Então, a gente poder olhar para a saúde mental como algo constitutivo do ser humano, algo que todos nós temos, algo que todos nós temos que cuidar, é algo fundamental. E acho que esse olhar que o Brandon vai trazer um pouco aqui hoje, ele nos abre essa porta. Eu pedi que ele nos falasse um pouquinho sobre um artigo que ele escreveu há uns 5 anos atrás, que é por que nós cuidamos? Por que nós cuidamos uns dos outros? Né? Ao longo dos últimos anos se debateu muito do ponto de vista evolutivo de pensar a origem das doenças, de por que a gente adoece. Né? Por que a nossa espécie está programada para ter algumas doenças? Mas a gente discutiu muito pouco, e o Brandon vai nos falar aqui, por que a gente cuida uns dos outros. Eu acho que aqui a maioria somos profissionais da saúde, então acho que isso vai falar muito com a prática do dia a dia de cada um. Eu podia falar muita coisa sobre o Brandon, que ele tem um índice H de 75, né, dezenas, centenas de publicações. Eu acho que esse não é o foco principal, né? O Brandon é um grande amigo que tem vindo a Porto Alegre agora quase anualmente. Ele esteve aqui ano passado, imediatamente depois das enchentes, desceu lá em Canoas, na base aérea, né? Enfim, conheceu toda, viu a situação, e agora ele tem a oportunidade, inclusive, e a gente nesses dias está trabalhando no desenvolvimento do protocolo de intervenção do projeto Recomeçar, que é uma iniciativa PROAD, em que o objetivo vai ser oferecer suporte psicológico breve para as comunidades afetadas pelas enchentes aqui no nosso estado. Então, é uma possibilidade de uma sinergia muito grande, mas vou parar por aqui porque eu quero escutar o Brandon também. Please, Brandon, the floor is yours. Eu esqueci de mencionar uma gafe minha, que ele é professor titular de psiquiatria na George Washington University nos Estados Unidos.
Bom dia a todos. Fortunately, that was as much Portuguese as I could do, so my apologies in advance. I'll be doing this in English, but then we'll do our discussion and question and answer in Portuguese. I wanted to say thank you so much to Dr. Nazi, to Dr. Abreu, and of course my good friend and colleague, Dr. Keeling, for the opportunity to speak with you all today. So, as Christian was introducing, my background is really a mix of psychiatry and anthropology. So I do a lot of ethnographic work, traveling to different parts of the world, look at things like traditional healing, but also work in a hospital, think about medications, evidence-based psychiatric and psychological treatments, and try to bring those two things together. So what I want to talk about today is a better understanding from an actual evolutionary perspective of the healing practice, and how maybe that can be something that is useful for all of us as we think about good hospital care, good primary care, good specialty care. Okay, so just my disclosures and conflicts of interest. The funders are all listed here. Most of the work comes from the National Institute of Mental Health. No pharmaceutical conflicts of interest, and all opinions are my own, not my university's or my funders. So we'll chat for about half an hour, and I want to talk a little bit about the idea of evolutionary medicine. Many of you have maybe heard this term before, and then go into the ideas around evolutionary psychiatry, and specifically the evolution of helping or caring behaviors. Then I'll spend most of the time talking about how this evolutionary perspective can actually improve diagnoses in psychiatry. Dr. Nazi and I were just talking about diagnoses a moment ago. And then as Dr. Keeling mentioned, just spend a moment talking about our work in a project in New York City and how we're very excited that now the Recomeçar team will be replicating and expanding upon what we've been doing in New York here in Porto Alegre. Okay, so evolutionary medicine is a field that's about 25, 30 years old, and it really came out of the idea of better understanding of the origins of diseases. Some of the ideas around things like mismatch, that what was an evolutionary advantage 500,000 years ago might at this time be things that put us at greater risk for disease, and also how adaptations in one setting can actually put us at increased health risk in other settings. So for those of you familiar with evolutionary medicine, the most common example tends to be the understanding of sickle cell disease and malaria. The question being, why do humans have sickle cell disease? It seems like it's something that is putting life at risk. It's a very uncomfortable condition, early mortality. So why would that be in us as human beings? Well, the realization that the distribution of sickle cell disease historically is in the same areas with the highest concentrations of malaria, and being heterozygous for the sickle cell trait is actually protective against many of the effects of malaria. So we understand that a disease actually has an adaptive function. Also understanding like things about lactose intolerance and different distributions of digestion are really tied to the historical environments in terms of what food was being produced locally. So we can better understand a lot of diseases with that evolutionary history that anthropology brings to medicine. Now, of course, all of medicine is about Ozempic and GLP receptor agonists. This is also something that we can actually much better understand how to treat diabetes from understanding the evolutionary origins of our eating behavior rather than just always treating the symptoms. We've been treating the symptoms of diabetes for 50, 75 years now, haven't made a lot of progress. But if we can actually tackle the behavioral drives that lead us to potentially overeat or eat unhealthy ways, that may reduce these risks. So it's actually an evolutionary understanding, thinking about how in history, not just human history, but even before humans, we were foragers. And so whenever food was available, we would eat whatever was there. But we didn't get full because we didn't know when the next pile of berries or fruits or other things would be available. So we eat more than we need in the moment. Today, that doesn't work very well. Today, there's always food available, and constantly eating beyond what is healthy puts us at these risks. Therefore, something like Ozempic and the GLP receptor agonists help to combat some of these evolutionary drives that are unhealthy now. So the main figure in the field of psychiatry that has tried to take an evolutionary perspective is Randolph Ness. He works and actually runs an evolutionary psychiatry clinic. So helping to understand the origins of anxiety, the origins of depression, the origins of PTSD, that a lot of these may be adaptive mechanisms in small doses, but what happens is that when these things get kind of out of control or go too far, we end up with psychiatric disorders. But I want to reorient us for a little bit and actually not think about the patients that you may see up in the hospital, but actually thinking about ourselves. So much of evolutionary medicine, evolutionary psychiatry has focused on what are the origins of disease, but for the most part, no one has really looked at the evolution of healing. Why do we do the behaviors that we do? Why did you all go into the health profession? What is it about our behavior with others that actually drives towards healing and helping people feel better? And this isn't just relevant for psychiatry, where we're always trying to use the best psychological and psychiatric interventions, but as we know, good primary care, good cancer care, good care in any field involves this human relationship. So what are the evolutionary origins of that caring and consolation, and how can we better promote that? So when I first started anthropology training at this point more than 25 years ago, we were beginning to see a shift away from a lot of the early Darwinian understandings around health and well-being and genetic inheritance, and moving away from that idea of kind of individual level selection, survival of the fittest individual one person, to what we now refer to as multi-level evolutionary selection. That actually evolution, even prior to human beings on many social primates, has operated at the group level. So groups that are effective, that are cohesive, that are able to hunt and forage together, that are able to help collectively raise infants, that group has better survival. So what genes have led to kind of those group benefits rather than just always thinking about things as an individual? I try to illustrate things whenever possible with cartoons to make the point. So a lot of what we think about in terms of evolution is the idea of what made the individual do well to get away from the saber-toothed tiger. But our understanding now is actually the biggest threats aren't the saber-toothed tigers, it's other human beings. It's competition with other groups or being able to be a member of a group. So for much of Homo sapiens history, it has been those group threats or group-based benefits rather than one individual surviving the attack from a saber-toothed tiger. So Randolph Ness writes about this in terms of the origins of distress as being things that especially put us at risk of social rupture, being kicked out of the group, kicked out of the community, kicked out of the club in some way. So many of these things, loneliness, guilt, grief, anger, fear, anxiety, they are interpersonal emotional states that often drive us to stay together in groups. But if we only had drives to basically have people kind of draw in and we sometimes kick people out, how would we be able to sustain the groups? Other individuals therefore need behaviors around social healing, social consolation. When we see somebody else in distress, our response is to care for them, to help find out what's going on, to probably try to solve their problems or at least comfort them in those moments. And these behaviors, of course, are especially important in terms of child rearing in our immediate family, but those consoling behaviors, those helping behaviors, don't end with our own biological children. As we form groups, we care about others in the group. And in many ways, that has been selected for over evolution to be able to keep the group alive, to keep the group thriving. So we see all of these other evolutionary drives that are part of our professional life, but also every human's life, things like promoting social inclusion, acceptance, comforting, providing forgiveness, calming individuals who are in distress. All of these things are part of a drive to help support this emotional cohesion. So if we think about other non-human primates, a lot of this comes from actually physical contact. The most basic form of response is touching another who's in distress. We refer to this in many species as the idea of allo-grooming. It's when you see chimps kind of picking off bugs or just gently touching another ape. So what happens in terms of the response is that we see someone else in distress. We all know of mirror neurons and our ability to then feel some of that same pain or suffering internally. We have shared affect. That then triggers us as the healer or the helper or the consoler through executive processes in the frontal lobes to do our own emotional regulation, reduce our distress. And then from there, through things like touch and physical contact, we can comfort others. But it's important to remember that we are very much symbolic beings. And so we do that now through language as a key tool, but also through symbols, symbolic healing, all these other practices you see in traditional healing in many parts of the world, but even in modern medicine as well. And the key biological aspect of this is that when we provide consolation to others, there's a psychological feedback loop. We feel better about ourselves once we've been caring, nice, helpful to others. But there's also a lot of actual physiological benefits. If we think about something called the conserved transcriptional response to adversity, or the CTRA in genetics, that's the series of genes that downregulate inflammation and upregulate antiviral control. So the more CTRA activity that we have, the healthier we are. Lower inflammation, better to fight off disease. Well, helping others triggers that CTRA response. So there are these physiological and these psychological benefits. But we don't help everybody, do we? And we even know through neuroscience that often when we see others in pain, we may actually feel pleasure or joy or satisfaction. I don't know if there's a corollary in Portuguese. In English, we don't have the word, but the German phrase, Schadenfreude, is the one that really captures this, that pleasure in others' suffering. So there's been a lot of research around sports teams that when you see the enemy's team lose, you feel better even if your team didn't win. But that creates a problem, because if you're feeling pleasure at others' suffering, when we think of ourselves as clinicians or healthcare providers or just good community members, if you don't consider someone else a member of your community, you don't have that same empathic reaction. Helping them, you're not driven to do that. And if you were to help them, you don't get the positive feedback. So what we try to do through my lab's team, collaborations with Dr. Keeling and others, is think about how do you set up the conditions to ideally promote this empathy and exchange to make healing more effective. So a lot of our work is about these ideas to help healthcare providers, whether that's a community health worker, a non-specialist, or a psychologist or a psychiatrist or a primary care worker, better see their patients as human beings, part of the same group, to mobilize that evolutionary positive response. So I just want to take a few moments and describe one of our projects around using and leveraging this process to improve diagnoses, and also to then provide an example of the Recomeçar work as a way to address this. So if we look at primary care services around the world, and even with a lot of proliferation of the World Health Organization's initiatives, in many cases, primary care workers are not ideal at diagnosing mental health conditions. Even as psychiatrists, we struggle with this. But after many trainings, now it's been used in more than 100 countries around the world, the World Health Organization's program on training primary care workers typically yields lower than 10% identification of who needs care or services. And a lot of that problem tends to come from the idea that those primary care workers stigmatize or discriminate against people with mental health conditions. They don't see them as part of their group. And the training is not about promoting empathy, it's about just understanding a diagnostic checklist. Well, checklists don't evoke empathy. So what we've started to do is to use processes wherein we train people living with mental health conditions to tell their story to clinicians like yourselves to better evoke empathy. So this is rooted in social neuroscience and medical anthropology, and it's the idea that if we could find ways for you as a clinician to see a patient as part of that same group, a shared humanity, then you're going to have that empathic response and better understand their experience and hopefully be a better diagnostician. So what we've done in Nepal and now replicated this in many countries is we use a lot of visual cues to basically create that connection. So we actually train people living with severe mental illness in photography to create photo-based recovery stories. What is it like to live with severe mental illness? What is it like to go for treatment? And what does recovery mean to you? So rather than me getting up in front of you and reading the DSM characteristics, we actually have members of our group tell these stories through pictures. We then embed this in the training so that rather than just a psychiatrist training a primary care worker, we, for every condition, have somebody come up and share their photo-based story. So I don't have time today, but happy to share this material with others. But here's just an example of somebody living with alcohol use disorder. And so he has pictures of how he just bought alcohol, he didn't spend money on family goods, some destruction of his house when he was violent and intoxicated. He has these two bridges, and he says living with a substance use disorder is always having two bridges in front of you, but picking the wrong one. So he kind of shares that as his experience. He talks about the people in the community who helped him. And his understanding of recovery isn't just that his symptom scores go down, but it's being economically productive, being able to raise goats, and also being proud of his family and his house and sharing that with others. So he provides this long, like 10 to 15 minute story, and then the primary care workers have a better understanding of that condition and hopefully empathize more. So our work has showed that these trainings not only reduce stigma in the short term, but even up to a year later, we still find more positive attitudes. But even more important clinically, we find that people that hear these stories compared to standard WHO MHGAP training, they diagnose many more patients, they provide more mental health services, but most importantly, their diagnoses are more accurate. 40% versus more than 70%. So they're better able to understand another person's experience and accurately diagnose. And what I think is especially important for psychiatry is with standard training, we get a lot of false positives, or basically somebody coming in and then the doctor telling them, oh, you have psychosis, you have schizophrenia. And if you don't, and you put on an antipsychotic, there's lots of negative side effects. So reducing these false positives and getting accurate diagnosis is so important. We just have wrapped up a large trial with over 8,000 patients in Nepal, and we've also expanded this to 6 other countries. So just to wrap up, I want to bring up one other key point about evoking these natural healing processes. The other is often healthcare providers are of a different economic background, different educational background than many of our patients because of what we have access to. There's an increasing use, though, of task-sharing non-specialists, people from the community who have shared life experience, shared economic, educational, linguistic, religious, cultural background, and those groups can better leverage that shared experience to be more empathic. The World Health Organization now has many manuals. One of them is called Problem Management Plus, Enfrentado Problemas. Okay. And when we use that, the healers, the helpers, and those in the community who have suffering those conditions are better able to identify with one another and tend to have strong psychological benefits. There's now been multiple meta-analyses showing that non-specialists can effectively deliver these interventions in their own communities. We initially did this work in Nepal, but brought it to New York during the pandemic and deliver it now throughout New York City. And I love this quote that really captures it. So one of the people that we trained who had no mental health background, after the training and delivering services, she said, people who are unlettered, they don't have an MD, PhD behind their name, have been taking care of each other throughout time. The clinician is not the lead here. It is the person who has the concern, an important shift in paradigm. And what I'm so excited is that we've gone from Recoup New York, which is our project in the US, to now being able to do Recomeçar here in Porto Alegre and Rio Grande do Sul. And all of the materials are now being culturally adapted for the local community. These will all be available in Portuguese. Thank you so much to Anna, who's translated so many materials. And these are now freely available through the WHO website for anyone to be able to use to help empower local communities to respond to mental health needs. So thank you all very much. I just want to conclude by saying that evolutionary medicine is a great tool. It's especially helpful not only understanding disease, but understanding how we better train psychiatrists, psychologists, non-specialists, nurses, and others. Ultimately, through that, we can better understand motivation. For any of you that are interested, this field of psychological study is now referred to as contextual behavioral science, and there's a growing number of publications about this. And if you're interested in learning more about the EQUIP resources and the interventions in Recomeçar and other similar programs, here's a QR link to the EQUIP website from WHO. Muito obrigado.
Muito obrigado. Eu vou pedir para todos sentarem e vamos fazer um período de debate. Nós temos 20 minutos de debate. Bom, por favor. Talvez, para esquentar perguntas, talvez, Christian, faz um pequeno comentário sobre até esse projeto que o hospital está envolvido de...
Claro, claro. Então, no projeto, I'll talk a little bit in Portuguese, o Brandon ele está se virando com os cardápios aqui de Porto Alegre, que em tudo que é restaurante que a gente vai, ninguém tem cardápio em inglês. Então, se ele está se virando com os cardápios, acho que ele vai conseguir entender aqui. Mas falando um pouquinho do Recomeçar, né, um projeto proposto, liderado pelo Dr. Regis Rosa, né, que enxergou, né, o grupo aqui, na verdade, enxergou essa demanda, né, depois dos eventos do ano passado, e, enfim, a gente vem conversando, e eu me juntei ao time agora este ano, para viabilizar que a gente possa, em larga escala, então a ideia é realmente atender centenas, né, de pessoas afetadas, das regiões afetadas pelas enchentes aqui no estado do Rio Grande do Sul, no ano de 2024, do ponto de vista de cuidados psicológicos, né? Como o Brandon estava falando, a nossa espécie, ela tem, né, dentro da gente, na nossa constituição, essa capacidade de cuidar um do outro. Evidentemente que não basta só a vontade, a gente precisa ter ciência também e estrutura para isso. E o que o projeto Recomeçar, através desse manual que é o EP+, o Problem Management Plus, pretende treinar facilitadores que vão estar sendo supervisionados por profissionais da psicologia para implementar, então, esses cuidados em larga escala para a população afetada. A população que foi afetada é uma população que sofreu eventos traumáticos, né, que a gente sabe que são gatilhos, se não fatores causais diretos de problemas emocionais. Então, o projeto Recomeçar ele vai estar muito focado em sintomas relacionados à ansiedade, relacionados à depressão, também alguma coisa na linha do estresse pós-traumático, mas a gente entende que o objetivo aqui é a gente ter cuidados mais amplos de saúde mental. Uma coisa legal que eu acho até do nome do Enfrentando Problemas, e lá no iniciozinho, na introdução do manual, a OMS deixa muito claro, né? A ideia não é resolver os problemas, até porque a gente sabe que muitos problemas a gente não tem como resolver totalmente, mas enfrentar os problemas de uma maneira mais positiva, né, e que não seja um impedimento. Então, a gente está no momento agora, essa semana, a gente está avançando em várias frentes, aqui a Geraldine tem coordenado toda essa evolução desse trabalho, né, e a gente está com o Brandon aqui desenvolvendo muito o treinamento dos supervisores e dos facilitadores. Então a ideia é a gente poder realmente ter uma equipe grande que vai poder escalar. A gente vai fazer esses atendimentos através de teleatendimento a partir do hospital, justamente para ter essa capilaridade geográfica. Mas enfim, estou falando demais aqui, queria abrir para a plateia e ver se alguém tem algum comentário. Fiquem confortáveis de fazer em português ou inglês, a gente organiza aqui a tradução se for necessário.
Para a pessoa se identificar, porque a gente está gravando.
Hello, my name is Leonardo. I'm a neurologist here at the Hospital Moinhos de Vento. I also work in Paradisus in another project, so randomized clinical trials. But my question is, around your work, the work you've been doing so far, and all the literature that is available, do you see the role of spirituality? And how do you see the role of spirituality towards the development of global mental health diseases? We are in a moment, there is a critical moment and religious confrontation between several groups, not only in the Middle East, but around the world. How do the literature approach this, the development of spirituality or religion, and its role in developing or healing mental health issues?
Great, thank you very much. Can you translate the question? Or okay. So I want to distinguish between religion and spirituality. And I think that's very important when we talk about spirituality and health, spirituality and medicine. There's a lot of very important things to raise, and I'll raise a couple of those. I think for religion, it's a more complicated issue, and we need to be sensitive, but also engage with it. When we talk about spirituality, there's a lot of finding that having a spiritual life, a connection to meaning, a connection potentially to a higher power, whatever that may be, that is incredibly salutogenic. It's incredibly healing. There are two ideas of kind of pleasure in positive psychology research. There's the hedonic pleasure, things that just make us feel good, that are kind of gratifying. But another term that's increasingly used is eudaimonia. And that's kind of the pleasure and satisfaction that comes from having meaning in life. And that is often very strongly tied to spirituality. So helping, especially as a psychiatrist or a psychologist, or dealing with patients who maybe have terminal health conditions, talking about spirituality can be very helpful as a way for them to identify with meaning in their life. So I strongly encourage people to explore that in their own clinical work and in research, and even in WHO's definition, it does include spirituality there. For religion is kind of aspects of spirituality, but it's also an organized political system. That structures can be very important in different settings. So for example, a number of our pictures were from Liberia. And when we've trained primary care workers, they say, I can't treat mental illness because God did that. And if God made that person crazy and I try to make that person better, God's going to punish me. And there are actually some traditional beliefs around this, that if you take the suffering away of someone who God has punished, then he will, put that suffering on you. So when we do our trainings, we have people come in to share about their experiences, but we also bring in imams, we bring in pastors, we bring in priests who either read from the Quran or they read from the Bible and say, look, God wants you to help people. God gave you a gift, and that gift is to be able to help people. But only once they hear that do they then pay attention to anything that I have to say. So in those cases, that partnership is very important because it legitimizes for the healthcare providers that they should be able to do this. In other settings, we may partner with different folks, but also there may be things that may be at risk for a person's health and well-being. And so it may be helpful to be separate from religious institutions, especially things related to certain forms of identity or religious persecution, that mixing those could be problematic. But yeah, thank you for raising it. It's a very important point.
Well, thank you for your presentation, Professor. But we have many questions about the anthropology medicine. You think that this is a new area in medicine can change the mind of the people of this mad world that we live today, especially the question this new war of incredible disadjust of the behavior of peoples. What do you think medicine can contribute, or especially anthropological medical, to these new times in the new century?
Mm-hmm. So there's a field of anthropology called critical medical anthropology, and it actually came about late 70s, early 80s. And it was basically lots of clinicians, doctors, people working in hospitals who were very frustrated to feel like, I'm kind of at the end of the river here. All the suffering in the world comes through the doors of our hospital, and I'm trying to help, but actually it's all these upstream political, economic, violence, war things that are driving all of this suffering, physical health suffering, mental health suffering. So critical medical anthropology was a push to say, how do we better understand the systems that may contribute to more health in society? Because simply as a single clinician, you are not going to be able to address that alone. So that has led to a lot of the work, also another physician anthropologist, Paul Farmer, and Partners in Health, and Jim Kim, who ran the World Bank for a little while. So a number of folks who said, look, we need to change the systems for that to be more effective. So I think that can be more of an anthropology of systems, society, and economics. There's also the push in anthropology of just understanding human behavior. What are the drives? what allows us to cooperate, what enables us to maybe not cooperate or fight or be abusive to one another. So understanding those origins so that we can identify those and try to modify those in society. I will say, as an anthropologist, to be very open, we constantly struggle because still in the mind of many anthropologists, you walk into a village and you sit there for 3 years and you don't say anything and you don't change anything because you don't want to alter some other society. So getting anthropologists to get up off their chair and go and actually try to help people sometimes is a little bit harder. But I think a lot of the theories and knowledge can be used by people in the health field.
Doctor, thank you for your presentation. I want to question you about the struggles your team had when you have to training people to start this process of making a diagnosis of the mental health for the people. What did you feel like there was something competency-based that you need in people for training, for diagnosis people in mental health?
That's a perfect question. Do you want to come and work for our team? Because that's exactly the kind of questioning that we need. So we found a couple of things. One was you can have systems of diagnosis, and they're not great, but there are some systems. But often people didn't use them for a couple of reasons. One was the feeling that even if I can identify and diagnose, I can't treat. I can't make it better. And everybody in healthcare wants to make things better. You want to feel like you have self-efficacy, you can impact people's lives. So an important part was realizing that you can actually do effective treatment, which is why we had people living with psychosis or depression or substance use come in and talk about their recovery, because then the health workers felt more like, okay, I want to learn because I can make it better. Because if you tell them, here's how to diagnose these things, but there's nothing you can do about it, they're not going to pay attention. They're not going to care. But the other thing too was feeling that they might be stigmatized if they start the work, right? So that I'm sure, Dr. Abreu's never had this happen, but sometimes people look down on psychiatrists and say that's not real medicine. That the idea that if you are taking care of people with mental health conditions, you're a lesser doctor, you're not a real or a psychologist. So another thing was also bringing respect to the practice of providing psychiatric services. So those things needed to be there alongside the knowledge of what, say, a diagnostic checklist is. But you have to bring them all together.
Thank you so much. It kind of remind me something we talked before, that we have a problem and we don't need solve it. We need to pass through the struggles, I think it's kind of makes sense with what you said to me now. Thank you.
Thank you, Professor, for your excellent lecture. I have a question. It's just changing a little bit the topic and talking about health, mental health in health professionals, particularly in physicians. We know that there is an increasing numbers of burnout in specific specialties in medicine. And I would like to know your thoughts about this. What are the causes, the main causes, and what we can do to decrease these stressful moments that are increasing in medicine?
Can I come back for another grand rounds? Yeah. So this is so important. I think this is very, very important. And a lot of the work we've been doing, I think, has important things to say about this process. So, in COVID, there was a lot more burnout, but it's not like as COVID went away, this burnout resolved itself. Many healthcare professionals still feel a lot of burnout. So some of the stuff that we've been looking at has been related to the issue of kind of empathy in the healthcare system. And many of the types of technologies that we're introducing in some ways actually block or impede the empathy. So as I talked about, the origin of kind of consoling others is human touch, right? Being in the same space together. But even if we're not touching, we have communication, we're sharing, we're engaging, our emotional alignment is happening. But that's really hard to do hour after hour after hour over Zoom or Google Meet or any of these different technologies. That empathic relationship is harder to provide the positive feedback to a healthcare worker. So you're not getting the same kind of psychological benefit as healing in the same space. The other is, I don't know about, Muñoz de Vento, but in our hospital now, there is so much documentation. There's a scribe in every room. There's like the AI running at the same time. So the person is kind of there, but they're not the center of the engagement. And so again, I think the healthcare worker doesn't get what's positive about that interaction because of all of the other distractions on our attention. So I think finding ways to still leverage the best possible technology in the world, but maintain that connection would help to reduce burnout.
Thank you for your presence. Thank you for and your ideas. And my name is Lorena Calefi. I'm a psychiatrist here at the hospital. And for me, it was really interesting to know all this project, the idea of training the community on diagnosis and detecting mental health problems in the community. But I was thinking maybe it wasn't clear for me, but how the treatment after the diagnosis will be provided for the community. Well, our health system is not the size we need for the necessity of the population. So I would like to know what it will be this idea to provide the treatment after the diagnosis is done. Thank you so much.
Great. Thank you for asking that question. So one of the things is finding treatments that are available that are not going to be specific to a particular diagnosis. Like, so in psychiatry, referring to like the transdiagnostic treatments. And what's very nice about the Recomeçar project is the Enfrentando Problemas that can help somebody who has a substance use condition, somebody who has anxiety, depression, PTSD, if somebody's stable but have maybe some history of psychosis. For all of those, that can be helpful in terms of managing stress and promoting well-being. And that, as we talked about, can be delivered by people at a community level with about 40 hours of training. So that's nice because it doesn't have to rely on somebody getting a specific diagnosis and could be available to almost anyone. So hopefully through Recomeçar, we'll be able to get more data and research around who benefits most, demonstrating the competency and the effectiveness of the providers that are being trained to do it. So that's one aspect of, can we get more services that are not diagnosis specific, because diagnosis is so hard to do. The other thing I will say briefly is that in our projects with the World Health Organization, we've found that actually after the diagnosis is done, most primary care workers are pretty good at treatment. The treatments are rather regimented. Here's this medication, or here's this manualized psychological intervention. They're not so bad at the treatment part. That actually is okay. The real hard part is getting accurate diagnosis. And so if you only identify 1 out of 10 people with problems, you could have the best treatment, but you're not actually finding the people you need, which is why we need systems to improve diagnosis.
Hi, I'm Fernanda Kramer. I am a radiologist. But as you mentioned, positive psychology, and I'm a huge enthusiast of positive psychology. I thought that, do you think that programs like Recomeçar can have, as you're going to, if I understood, you're going to train people from a specific community to help their community. So with that, do you think that we are really going to have like more positive relations? And as I would say, as like an accident or a positive spiral, will have an impact in other areas of that community. You know, because like you have more positive relations, and then when you see you are acting getting these people, you're getting these people to have more power, you know, to like struggle in other areas. So it will have benefits in many other areas of this community, not only in the mental health area, but I mean, it's all linked or something like that. Do you think so?
I'm not sure that I believe you that you're a radiologist, because you talked much more like a community psychologist.
Because I actually am a radiologist.
I believe you. I believe
you. Radiologist, but I actually I studied positive psychology. Like I had a post graduation in that area. So
so what you bring up is a main goal of the program. So I won't go into all the details, but there are 5 different sessions for Problem Management Plus. The 4th session is about better engagement with the people in your life around you. So learning to reach out to ask for others for help, who in your community can be supportive of you. But the 5th session in PM Plus is to basically make the patient or the client, the person receiving it, a mini helper in their own community. Because in the 5th session, what you do is you then brainstorm with your helper, with the person who's giving you the treatment, how you can take it forward to your community. Because just like I talked about, we know that an incredibly healing behavior is to help others, that it has these positive psychological and physiological benefits. So if I can give someone 5 sessions of PM Plus, or better, their neighbor can give them 5 sessions of PM Plus, they're going to go out and then help others in their community. I have a colleague in Uganda who's doing an interesting study on task sharing, where he's not just measuring the people that are getting the treatment, but he's measuring the whole community to see, are there those secondary benefits by beginning to train a couple of people in PM Plus. They give PM Plus to help a couple others in the community, and then they go out and create stronger relationships, caring relationships with others. So that's really the goal, is the kind of community-wide dissemination of the benefit. So excellent question.
Thank you so much for your answer. I forgot to mention, because I'm also part of the, how do we say it, lifestyle medicine group from the hospital. So that's why I really like all these other subjects.
Right.
I'll make you an easy question. I mean, Brendan and I have been collaborating in multiple fronts, but one of our strongest collaboration is through the IDEA consortium. IDEA stands for Identifying Depression Early in Adolescence, and thinking about evolution, evolutionary medicine or evolutionary psychiatry. How do you see the new generations? I mean, is evolution working in terms of making us better healers? Do you believe that the new generations are going to be better healers than we are? Or, I mean, that's an easy question, right?
Yeah. Well, I mean, nobody will be better healers than we are, so that's easy. I think there, and we've talked about this, you know, there are so many generational differences, and the difference between generations in terms of the experience, in terms of communication, that we need the healing systems and healing relationships to kind of evolve just as fast as the technology is. So unfortunately, we're probably not the people that are going to answer that question. It's probably our kids that'll have to do collaborative research. But I think we absolutely need to better understand how social relationships are working in this changing technological world, changing stressors, changing types of whom you can connect with. And I just think it's going to be a challenge unless we maybe change some of our thinking around what is an intervention, who provides care, who provides support, those types of issues. And ultimately, as you know, we've talked about as well, and back to positive psychology, if we continue to think about psychiatry as only what happens after somebody's diagnosed, we've already lost the battle. And so with this kind of next generation, what are we doing earlier? What are we doing prior to a diagnosis? How are we rethinking the stages of diagnosis to really be able to intervene and build these skills early to reduce kind of the people knocking on your door, Dr. Abreo's door, your door, and really starting early.
Hi, Andre Zimmerman. I'm a researcher and cardiologist, and it's a selfish question. In cardiology, I basically work with preventive cardiology. So whenever I see a patient with a heart attack, that's basically, that indicates some failure of the system. My question is, a lot of what I do involves behavior and, lowering blood pressure, LDL, all that. What actionable lessons can we learn as providers looking at a more holistic perspective in health that we can actually help people with the behavioral aspect of medicine to prevent not only mental health issues, but also heart attacks and dementia and all that?
Also, excellent question. So the intervention that we'll be doing through HECOMA-SAR has also had a recent study published in the Lancet. I think it was done in Malawi, using Problem Management Plus for chronic disease management. And so what they looked at were individuals who had metabolic disorders, so diabetes, chronic hypertension, and they introduced just these 5 sessions into the overall chronic disease management. And because there's not enough healthcare staff, they were using local community members that were running the PM Plus sessions, very similar to what will be happening in HECOMA-SAR. And what they found was that it reduced both the symptoms of chronic disease, but also the healthcare costs. They needed to come for fewer visits. They were more adherent to less invasive interventions in cardiology than needing an emergency room visit or a surgery of any kind. So, building similarly on lifestyle medicine, I think these kind of collaborative efforts that are more whole person care, so that if somebody, again, they don't need a depression diagnosis, they don't need an anxiety diagnosis, any of these types of low intensity interventions will help people manage day-to-day life better to hopefully then have more positive physical health outcomes in addition to the psychological. So that can be the next ProAJ grant there, is in chronic disease.
Devido ao tempo, só pegar o último inscrito, porque nós temos que encerrar pelo tempo. Mas...
Hi, my name is Alexander Dauchi. Thank you so much for this beautiful lecture. We are in the business of lifestyle medicine. Recently, we start our OPSI in this hospital. Congratulations to Dr. Nazi that help us too much in this direction. So just to thank you and ask we can continue with this kind of activities, because we just need to compose like a network, benefit of network, and so I will allow me to ask for people stay around on August 23. We'll be here. It's a webinar. It's not a live session, but will be a webinar with Dr. Simon Matthew. Dr. Simon Matthew is an expert in interventional, in motivational interview, and this is a lot of we need how to know more about skills, how to engage with the patients, and so we can try in the hard task that is building behavior changing. So I just want to be in part of this team, and Fernanda and the other members of our group will be grateful to be part of this. Thank you so much.
Bom, ok, eu acredito que os outros também que se motivaram e deveriam talvez participar ou entrar nessa rede, né? Sabemos a quem procurar, né? E para realmente melhorar a qualidade não só do nosso trabalho, mas também das nossas vidas, né? Então, bom, eu agradeço a presença e a disposição e torcendo para que esse programa aqui, na replicação de Nova York, funcione bem também com os nossos náufragos, né? Muito obrigado. Thank you.